As always, we'll give them just a few minutes to get in the room, and then we'll get going.
Yeah, we'll give everybody a few seconds to come inside, and then we'll get rolling here. Okay, well, good morning, everybody. I'm Jonathan Godbout. I'm the faculty director of the Chronic Brain Injury Program here at OSU. And it's my pleasure to introduce today's speaker in the Buckeye Neurotrauma lecture series. And this is a lecture series that we're doing, as to have OSU and Nationwide Children's Hospital researchers give a presentation, to internal and external colleagues. It's something we've been doing for a little bit, and enjoy the opportunity for this lecture today and introduce Dr. Ginger Yang, who is an investigator at the Center for Injury and Policy at the Nationwide Children's Hospital. She's a professor of pediatrics and epidemiology at Nationwide Children's Hospital and also part of OSU. She's really interested in injury prevention and recovery from sports-related injuries, particularly TBI in adolescents. She did her training at UNC Chapel Hill and then spent time at Iowa and Kent State before coming to Ohio. She's been very successful with grants, with being a co-investigator on 35 grants funded by the NIH and CDC. Also been awarded grants from the Chronic Brain Injury Program, and has been authored in over 150 papers. She has 2 current R01s, and I think she's been a very active member of our community, neurotrauma community here at OSU, and part of our advisory board for the Chronic Brain Injury Program, and been a great person I've enjoyed working with and interacting with. And it's really my pleasure for her to give her talk today on the physical and cognitive activity after concussion. So thank you, Ginger.
Thank you, John, for the introduction. It is very kind of you to say all the good words. I wish I every day work hard, strive to do the best to help our kids to be safe in the sports. Good morning, everyone. Thank you so much for joining us today. I really appreciate the opportunity to share the research with you. The title of my talk is Physical and Cognitive Activity After Concussion. My work has been funded by NIH and the CDC. I have no conflict of interest to disclosure. Here's the planning committee disclosure. If you have any question related to the CME, please contact Julie for the details. So I'm going to start with my talk today to discuss concussion as a public health problem in children, followed by a discussion on physical and cognitive activity following concussion, including evolution of clinical guidelines, clinical practice at NCH, and also our research progress. I will end my presentation today with the future directions. So as you probably know, concussion is a form of a mild TBI. It is a significant public health problem that can have adverse effects on the physical, cognitive, emotional, and sleep health. And although there are many concussion definitions, the common one used today define concussion as a type of a traumatic brain injury induced by a direct or indirect blow to the head, neck, face, or other part of the body that results in force to the brain. It is very important to note that concussion is a functional injury and not a structure injury. Each concussion is unique. Concussion can result in range of non-specific symptoms that vary in quantity, severity, and clinical presentation. That duration of a symptom also can vary from individual to individual. only about 10% of a concussion involve loss of consciousness, the CT and the MRI often is normal. Each concussion has a different symptoms presentation. Here are common concussion symptoms. Some patients may develop a symptom right away at the first several hours, while others can be days after injury. Some symptoms can be due to the injury directly, that trauma, while other symptoms can be in the symptom during the coping with the injury. So several scales have been developed, including post-concussion symptom scale, which we commonly used, also used in the study we conducted, which including 22 symptoms. Why do we study pediatric concussion? First, children and adolescents are the age group with the highest risk, particularly for sports-related concussion, because of their active lifestyle. Each year, about 1.1 to 1.9 million sports and recreational related concussion are sustained by US children. And the secondary, the concussion in children and adolescents are often particular concern since their brain are still in development until about 25 years old. So the brain injury during this period can impact their executive functioning, including judgment, problem solving, and the mental flexibility. And this injury can also lead to increased risk for long-term negative impact, including neurobiological and the behavior consequences. This is a graph showing significant increase in number of concussions, including new concussion and the recurrent concussion. The blue bar is a new concussion. The red bar is a recurrent concussion. About 10% of concussion are recurrent. Among the nationally represented sample of high school athletes who participate in 9 common sports, this including football, basketball for boys and the girls, soccer for boys and the girls, baseball and baseball and softball, as well as volleyball and the wrestling. So the observed increase is increased reporting, largely due to the reporting because the increased wellness and not necessarily increase injury, since all 50 states passed the concussion law. One of the requirement is concussion education. So increased awareness, seeing the increased concussion reporting. We also know that football had the greatest number of a concussion when comparing 8 other sports in this study, that more than half of a concussion is in football. The football also have highest rate. So the red curve here indicates the football. These are all 8 sports. So highest rate, that is the divided number of injury divided number of participation of a sports. One participation in the game of practice defined as 1 exposure. So when we compare the girls' sports and the boys' sports in the comparable sports, the same baseball, softball, basketball, and the soccer, girls actually have highest concussion rate consistently across the years of a study. Now I'm going to discuss the physical and the cognitive activity after concussion. So the traditional approach to managing pediatric concussion recommends that patient rest until they become symptom-free. The rationale is that rest helps avoid overexertion of the brain during the critical period of repair and allow the body send amplify nutrients and the supply to speed the process of a brain injury repair. And the study in human also show that engage in high level of activity too soon post-injury can increase the symptom severity as well as symptom duration. And it can also lead to more neurocognitive or functional impairment. In 2015, one of a landmark study conducted showing that complete rest, especially for the extended period, may be unnecessary, impractical, and do not offer any significant benefit. Prolonged rest could also lead to muscle deconditioning and withdrawal from school, sports, and other activity, all of which have negative impact on health and well-being of youth. As you see from the graph, this is a randomized trial. The group as an intervention group have prescribed a 5-day strict rest at home, while the other group just usual care. The result is showing that strict rest does not offer any additional benefit compared to the usual care. The most recent clinical guideline, also known as a Berlin concussion consent statement, recommend a brief rest acute after the injury, and that the youth can return to activity gradually, progressively, as early as 24 to 48 hours post-injury. However, this guideline are based on expert opinion, not a strong evidence-based. So the exact amount and the duration of activity is still not well defined in the literature. In 2029, the group Dr. Lady, John Lady, and his team conducted a randomized trial that demonstrate that individualized, progressive, and sub-symptom threshold aerobic exercise prescribed within 10 days after concussion actually have a benefit to help promote the recovery. So the graph in the left indicate this is the group of prescribed as aerobic exercise in the blue. The orange is a control group. They have them to do the stretch exercise. So the intervention group with aerobic exercise actually have a faster recovery time. In the right, this graph indicate the intervention group actually have a lower symptoms severity at each day during the 21 days of the study. So basically, this group also prescribe exercise individualized. They have them to do the treadmill test. Then based on the test result, they prescribe the exercise at 75 their maximum height rate or 80% height rate, maximum height rate. So in that way, the participant can exercise to the maximum benefit without increase the symptoms. So now I want to talk about the practice at Nationwide Children's Hospital. This past summer, we had a medical student work at OSU, worked with us on the analyze electronic health records to see how the clinician prescribe the physical activity during the first week post-concussion. So as you see from the chart, the findings showed that from 2009 to 2012 to 2019, the physician prescribed physical activity recommendation shift from majority prescriber no PA, that is a blue line showing in the 2012, almost 87% prescribed no physical activity, to today that 2019, that is less than 40%. And also the light activity in the 2012 was 11%, right now is about 53%. So the shift from no activity to more light aerobic activity indicates the practice have been changed with the guideline, with the evidence. So still, what is the optimal level of activity, how that relate to the recovery is unknown. In last past 8 years, our team has focused on research on the concussion acute recovery in children and adolescents. We have done quite a bit of research with acute recovery. We look at how policy, concussion law impact healthcare utilization. We're also looking some biomarkers associated with concussion prognostic and recovery. So in today's talk, I'm going to focus on some of our findings relate to optimal physical and cognitive rest after sports-related concussion. We use a prospective cohort design with a repeated measure. We enrolled youth 11 to 17 years old with a physician-confirmed concussion. We assess the 3 times after the enrollment, monitor their recovery, either until their symptom-free resolution or the 45 days after injury. So we conduct the 3 assessments. First is within 72 hours, second is 1 week after their assessment 1, the other is at a symptom resolution or 45 days post-injury. We have them wear the autograph and heart rate monitor that is monitor their physical activity. So the autograph is just research grade of a Fitbit. So we recorded their step counts and also the activity intensity. So we also have them wear a mimic camera that called a narrative clip. I don't know if you can see, this is just the narrative clip. That is a camera recorded outward, recording the activity every 30 seconds continuously. So that is allowed to recording the cognitive activity because what they see, that what they're doing can recording. To ensure that narrative clip measure a normal visual field, we use the 3D printer, a wedge, to have, you can see that the angle can capture holding the narrative clip. So in the place at the particular angle, so we can actually recording everything the youth seeing when they do the cognitive activity. After data collection, we use the computer vision to help make the coding process more efficient. For example, we use the color and scene structure to split the long sequence of a photo into meaningful segment. We use the deep learning methods to automatically label frame with the information tag. For example, this have a screen, TV screen, or this is just recorded did not take the photo. So we have the computer to do that, and we can separate those when we are doing the coding. We'll hope that help with the coding time. So we use the algorithm to stream analysis of a matched data recorded from narrative clip of a photograph with the autograph, the motion, by identify matched data point with similar characteristics, because both of this device have timestamp. So in that way, significantly reduce the data processing and the coding time. Now I just want to show the video indicate how the coding was done. The top you see that is a narrative clip recorded, and the bottom, the blue, all this line is the heart rate. And you can see the computer is moving automatically recorded. You can see the color in the center with the bar that in the same color is indicate the same activity. So the computer can select where the frame is, and based on the coding to code the number, the activity, the coding. On the top right, you can see the coding. Then they select the one to test it, the folder based on the activity recording down. So that just showing actually coding how that being done, give you some sense how we match activity with the coding with the help with NCH RECI group. And this is just showing go to next participant to bring the coding and do the additional coding. So. This is showing the driving there. They'll get to the coding to code the drive. Okay. So our study sample including 83 participants with 65% males, 35% females. The age group distribution was half of a participant between age 15 to 17. So this start with 11, 12, 13, 14, 15, 16, and 17. This is the sports activity they are participated with the majority, with 1/3 is the football involved injuries. And we also have about 16% non-sports related injuries. So here's some demographics and the injury information about the participant. We have 84% of injury involves sports activity, 29% youth have a previous concussion, and 48% of youth have a symptom resolution within 4 weeks. And also the symptom score at injury is 43%, 43 because the score is 0 to 132, so the 43 is their average symptom score. We also examined the first week because we only have them wear the camera on the first week. So we recorded their first week step count, how that associates with first week of injury. We see that injury, that step count increased, as you see from day 1 post-injury to day 7 post-injury, but the concussion, post-concussion score actually decreased from day 1 to day 7 post-injury. We also look at their daily activity, the intensity. As you see, the red line here is light activity. This blue is moderate activity. The green is vigorous activity. So the majority activity, more than about half of activity is light activity. The average minutes is 434 minutes. So that is almost 7 hours. That is a light activity. So the moderate is about 62 minutes. So that is about 1 hour, and almost no vigorous activity. We also looked at daily cognitive activity. This is recorded by the narrative clip, and we converted to the daily minutes of a cognitive activity outside of school, because the school does not allow children to wear the camera in the school. So everything here is outside school. So we see the outside school permitted, we see pretty much stable. This is the light activity, mediate intensity and high intensity. We also see the school time increased from day 1 to day 7. When the first day, that is about average 74 minutes, while the day 7 is about half day of a school. We then looked the first week that activity, how that associates recovery symptom duration during the study. So we find the increased daily step was associated with increased likelihood early symptom resolution. However, this association was not statistically significant after we adjust other covariates. The school, great school attendance was associated with both adjusted and unadjusted analysis, showing the great attendance was associated with early symptom resolution. And during this study, we also, in this study, when we analyzed the data, one of the questions occurred to us is whether the increased symptom is associated with early activity may associate fewer post-concussive symptoms, or fewer post-concussive symptoms, or may also predict increased activity. So we're trying to understand what is the chicken, what is the egg, how that is correlated. And then we divided the first week data or objective measure in the 3 waves, with the first wave is day 1 to day 3 post-injury, second wave as a day 4 to day 5 post-injury, and third wave of day 6 to day 7 post-injury. So we correlate this 3 wave with the step count and also with their symptom score. We find significant negative correlation. So indicate increased activity related to reduce the symptoms, and also reduced symptoms relate to increased activity, but we just don't know which way to which. So we conduct additional, So we conduct additional cross-legged panel model to analyze bidirectionally how the association of these two. So all the solid line here indicate is a significant association, with the dashed line indicate not a significant association. So when we see the auto correlation that from day 1 to day 3, day 1 to 3 to day 4, 5, to 6 to 7, that correlation is significant, both step count and also PCS. So that is auto correlation showing the significant, but only one cross leg that is significant, that is day 1 to 3 post symptom score is associated with the increased step at day 4 to day 5. So that is only one leg crossed. Then we also did the further analysis looking random intercept cross-legged panel model. What this do is the first model did not separate between and within person. But this model separates what is between individual, what is within individual. So the result indicate only the between person that correlation persists significant, but within person is not. So daily step and the PC score is significant stable. That is between participant, but no cross-leg path was significant. This means account between person difference, the within correlation will no longer significant, and indicate why the youth who engage in high daily step count reported low symptom than those youth who engage low daily count. So that group difference is there, but no cross-leg effect of physical activity and also PCS during the first week. Additional research is needed in this area. We also looked at the trajectory of daily symptoms, that is 45 days, how the symptom change, whether there is any patterns. So we find that when participants have a low score at injury, they tend to have better recovery. That is one trajectory. We also find those who have high symptom score at injury can either recovery sooner resolved, or they can have a persistent symptoms, not a recovery. But we also interesting find another group, even they have a low median symptom score, their symptom can be persistent. So these results indicate different recovery pattern and confirmed heterogeneity in the concussion recovery among children. These results may help a clinician identify concussed children with a slow recovery trajectory so they can implement early individualized treatment plan to foster optimal recovery. I also just want to mention one of a study we are currently ongoing is funded by NIH looking at driving after mild TBI. So we want to thank Chronic Brain Injury at OSU funded the pilot study to this one and lead us to get to the R1. This is a multi-PI, multi-site study. Basically, we assess driving performance among the teen drivers who have the injury. We enroll them within 96 hours. We follow them weekly to assess their driving performance. This is conducted at OSU and also University of Alabama. And the result, we expect our result to provide evidence to support development of clinical guidelines, particularly help clinicians make informed recommendation on when teen driver can safely return driving after my TBI. We are in the data collection process. We find not every teen drivers in our study can perform the driving on the driving simulator that within 96 hours. So in summary, self-paced, based on the first study looking the activity and the recovery, we find increased self-paced physical activity across the first week post-injury was associated with early symptom resolution in adjusted analysis, but not in the unadjusted analysis, but not in adjusted analysis. Great school attendance time was associated with early symptom resolution. These results suggest that self-paced physical and cognitive activity across the first week post-injury alone neither hastened or prolonged concussion recovery. So the youth with the concussion may have some latitude to determine their own activity levels. The second study, we're looking the bidirectional association. We find youth who engaged in more physical activity in the first week post-injury reported a few post-concussion symptoms than those who engaged less physical activity. Specifically, the post symptoms at day 1 to day 3 post-injury was associated with a lower daily physical activity at day 4 to day 5 post-injury. These results suggest youth who with great post-concussion symptoms may limit their physical activity, perhaps because everyone seeing the concussion clinic here at NCH, the physician also made some recommendation about refine their activity, because the data collection for this study is 2017 and 2018. So now probably will be different. Our trajectory study find that there is a distinctive symptom trajectory in children following concussion. These results highlight the importance of individualized concussion treatment and management plans. Now I would like to discuss the future directions. First, further study are needed to develop better tools that can be used to objectively measure activity, particularly objective measure document the cognitive activity post-concussion. It has been challenging document cognitive activity because, as I mentioned, school does not allow us to allow children wear the camera in the school that only measure the outward, what they see, not reflect what they did, only reflect activity, but does not capture the participant actual mental engagement in each activity. Second is it is very important to proactive exercise testing, identify optimal physical. Second most important, identify optimal physical cognitive activity to determine not only intensity, duration, but also timing of early introduction that activity. Right now have a lot of tools available, including the proactive exercise tolerance test that can identify what is the safe, valid, reliable activity that can recommend. So in that way, when kids have the physically ready to engage activity, we can recommend the duration, intensity, and optimal timing of engage that activity. The last one, it is very important to conduct a randomized control trial. So we do this observational study, not in the controlled setting, to evaluate the effect of physical and cognitive activity on the recovery, require the randomized trial, controlled environment, so we can ensure understanding what is the effect of activity on the recovery. And this study will also inform the healthcare provider recommendation on the physical and cognitive activity during the first week to facilitate concussion recovery. I want to thank all my collaborators and research teams, the funders, including OSU Discovery Theme initiated in chronic brain injury. Without their support, we will not achieve what we achieved today. I also want to particularly thank all the study participants who supported our study and provide their contribution to our findings. Now I would like open to the question. Thank you very much for your attention. I'm happy to answer any question you may have. Thank you.
Great, thanks, Ginger. And so a couple different ways you can ask questions. You can ask in the chat and I can read them, or you can raise your hand. We can let you ask, your question live.
John, we have one, excuse me, one question in the Q&A from Jack Cease.
Okay.
So I can read this out.
Sure.
Is there anything you noticed about the high symptom group that recovered quickly? What differentiated them from those who still took a long time to recover? This is in reference to the Sullivan study.
Yeah. This is a great question. So because it is an observational study, we did look at the symptom because we do the trajectory just affected them. We did not find any demographic information is associated with the recovery, the pattern, because they already counted those information. Originally, we think, okay, maybe female, because from all other study find out the different, but we did not find that distinguish among these two groups. Probably because we have a small sample size, but the analysis already counted those, all the factor in there. This is a very good question. We need further analysis because that is have high symptoms can be that we do find that those low symptoms, probably medium symptoms, probably the treatment attention may not be received as much as high symptoms. So good question.
And there was a follow-up, Ginger. I wonder if you looked at the type of symptoms that were reported.
Yes, we actually look at the type of a symptom recorded. The manuscript is under review. We're happy to share with the result. We find particular physical symptoms is associated with that recovery. So we're happy to share. At the top of my head, I cannot remember, but we do look at the profile, different symptoms, each symptoms, how that associates the trajectory. Email me, I can share the result with you.
Great, do we have more questions? Let's see.
Yeah, I've got Juliana Nemeth has her hand raised.
Okay, great.
Hi, Ginger, thank you so much for your presentation today. I was wondering, do you account for source of injury in any of these studies? And I'm also wondering if you collect data on the context, so not just the injury, but the context in which they're trying to make the recovery as you're, as you're looking at the recovery trajectories for these youth.
Can you ask that question? Are you asking the contact is after their injury, or are you asking the question at the time of their injury?
Yes, let me try to clarify. So,
Okay.
So there's two questions. The first is
Sure.
actually source of injury. So
Sure.
do you take into account the source of injury and control for that in the studies that you've done?
Yes, we have question on the one. Should I share the slides on the type of whether they injured in the sports, which sports they are injured? We
So
have that.
So this
info.
is all specific to sports related concussion?
Yes, we
Okay.
do have a 15, about 16% is non-sports related. So we have which sports they injured, and we have the information. We did not present how they injured. Are they contact a person? Are they contact the ball, or are they fell? We have those information about the injury, but I would 84% is not engaged sports, about 16%, 84% is the engaged sport activity. but the 16 is not engaged the sports activity. Does that
Okay.
answer your question?
Yes, yes.
Okay,
And
then you have a second question, right?
and the second question is around the context in which they're trying to recover. So do you collect any data about like the, you know, the home environment or, you know, the context in which they're making these recoveries?
We did not measure the home. We did do the daily survey. Like everyone have a daily survey. The trajectory you can see is a daily survey. So we daily survey, we ask them what are their symptom score, whether they go to the sports, what are the activity they engaged. We did not, today we just presented the first week. That is all the documented by the device, that activity. We also in the process writing is their activity, daily activity they reported. Either they engage the school and watch TV, how long they watch TV, how they do the text message, how they go to the school. We also measured their activity. Do they play the sports? How they, whether they walk, whatever. So we have daily activity, daily physical activity, daily cognitive activity. But we did not measure, say, you have, we do have their visit clinics, but we don't have the home environment. Those we did not measure.
Yes, okay. And things like social support, did you measure anything like that? No,
We did
okay.
not measure the social support. We only measure their nutrition, like what the food they eat, how much sleep they have. We actually working on the sleep, how the sleep affects the recovery. We do that, but we did not measure any social aspect. This is a very good question. Wish we included looking the social aspect. We did not.
Okay, thank you so much.
Thank you for the question. Thank you for coming.
Ginger, we have another question in the Q&A. This one's from Sean Rose. I think a similar train of thought. He asks, do you know prior medical history, ADHD, migraine, anxiety, depression? These have been shown in other studies predict recovery.
We have not, I don't think we measured specifically on the comorbidity pile injury. I wish we had that information. We have a previous history, but we did not have the comorbidity. I think if I do now, I will ask differently, but I think we just did not include in that question. Good question though. But I think if they are NCH patient, we probably can go back look in their chart. That can be linked. So, any other questions?
That's all the questions I have on my screen. Okay,
Yes.
Michelle Basso has one.
Can you hear me?
Yep.
Yes.
Great. I was typing it out, but I was afraid I couldn't type fast enough. This is just a data question. I'm wondering, was struck by the step counts that you were able to show. I think that was just in the first week, and that the peak step counts were around 8,800 steps. But I'm unclear about what you would expect those step counts to be for youth in that age bracket. I don't know what would be normal. So I'm also interested that 8,800 is well below the heart health guidelines, at least for adults. So I'm wondering just how low those are compared to their age match healthy peers. Thanks.
Very good question. That is, this is the step count that is probably supposedly the age recommendation, not for the concussion patient, but for this age will be higher than we looked the data should be, I cannot remember will be more than 10,000 step in the children, typical children in this age. That is, we see that day 7 probably exceeded, but the first couple of days probably lower than that. So that is definitely lower than the normal recommended step count. We also have, I did not report MET like that, the number, but that the first week in this group, you can see that is lower than average. But by the day 7, they meet the average recommended activity. Good question, Michelle.
Nice to see you again, Ginger.
Same
Great
here.
talk.
I also feel like you have been always very supportive to me and to our research. Every time I talk to you, I always feel like that has been always very supportive and learn a lot from your work.
Well, I'll be in touch offline. There's some really cool stuff you have. Thank you.
Thank you.
Any final questions? Let's see, anything in the chat? Okay. I'm not seeing anything. Kate, are you?
No, I think that might be it.
Okay. Well, I guess we'll let everybody go and enjoy your weekend. Ginger, thanks again. Excellent talk, and always a pleasure to see you and see the great work that you're doing. So thanks again, and take care, everybody.
Thank you. Bye now.